Okay. A very good evening, and to one and all who joined this webinar. It is again the monthly meeting of our fertility education program. I request Dr. Ramni Devi to give a gentle welcome to the gathering to all of them who have logged in.
Good evening, everybody. I welcome all the participants, faculties, as well as the participants for this entire program that is being done under the banner of Janani Fertility Center. And I think today we'll be discussing something about Mullerian anomalies, and that topic will be followed by a case discussion. So that will be a two-way interactive session, and I welcome all the participants for this program. Thank you.
Shall we have a prayer song? Or?
Prayer song? Vikas, can we have the prayer song?
Prayer song?
Yes.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் மதனமென திகழ்வரத கண்டனிதில் எக்கணமும் அதில் சிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம் வியந்து செய்ய மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Yes. Now to introduce about Janani Institute of Fertility Training. See, this was started about 8 months ago, and we are trying to reach all the people who are around the periphery and who cannot make it a point to come to the town or to a center for a regular CMEs. Okay. So we thought we can reach out to people who are a little away from the town so that they can learn a little more about fertility. So we have started doing from the basic things. We started with how to evaluate for the female partner, how to evaluate the male partner, how to read a semen analysis. So what is each step of fertility training. So in that, today we are dealing with uterine anomalies and how to treat with that. And so that we, try to combine that with a case scenario so that you understand better what will be the outcome of treating a uterine anomaly. So that is what is our principle of doing. We would like it to be a two-way program, because once you raise doubts, we can even clarify doubts even better, and we can reach out to people much more with clarity. That's the intention of the entire program. We try to do it with guest speakers as well. So people who are interested in infertility, when you come and join us and you give us inputs, we'll try to make it even better. So I welcome all of you to join us and make use of this platform so that we improve on what I want to reach to people, and you learn much more from whatever little that we know. Thank you, everyone. And I now request Ramni to go ahead with her lecture on uterine anomalies and its obstetric outcome. Thank you.
I will start sharing my screen. Are you able to see my screen?
Yes.
Okay. So let me thank Chitra as well as Gift for making me the presentation of this Mullerian anomalies and reproductive outcome, which is very close to my heart. And Mullerian anomalies are something very fascinating disorders to the obstetricians and gynecologists. Mullerian ducts, they form the tubes, uterus, cervix, and the upper part of the vagina. And we know that lower part of the vagina is developed from the sinovaginal bulb. The anomalies can range from agenesis to duplication. It is associated with renal and axial skeletal systems anomalies and has varying presentations ranging from primary amenorrhea to menstrual disorders, infertility, pregnancy complications like bad obstetric history, preterm labor, ectopic, etc. Mullerian duct anomalies has varying treatment from ability to have coitus in women who are devoid of the genital tract, as well as the vaginal agenesis is there, to the extent of making them conceive and deliver normal babies with the advent of so many newer technical advances in the surgical field of this correction of Mullerian anomalies. The incidence of Mullerian anomalies date back to 16th century. It was Colombo et al. Who discovered a first case of uterovaginal agenesis in the year 16th century. Then later, Byron et al. He found out in the general population it has an incidence of 0.3 to 3.5. And fertile women, it can still be 4.3%. In infertile women, the incidence goes up to 6.8%. And in women who are recurrent aborters in the first trimester, it is 5 to 15%. And in the second trimester, almost 15 to 25% of the abortions that are happening in the second trimester may be as a result of Mullerian anomaly. And among the Mullerian anomalies, septate uterus and the arcuate uterus are the most commonest, and they account to 75%. The anomalies can be either in the uterus or in the cervix or in the vagina and in the cervix. The vaginal and the cervical anomalies are most often associated with endometriosis. See, because we know in endometriosis, whenever there is an outflow or obstruction, there is a retrograde spill, which causes endometriosis. Then, why this Mullerian anomaly should occur? It is mainly because of the dysregulation occurring in differentiation, migration, fusion, and canalization of the Mullerian ducts. And it is quite often associated with the renal anomalies, axial skeletal anomalies, and rarely cardiac and auditory anomalies. The probable causes are intrauterine infection, genetic aberration, and teratogens like DES and thalidomide. The genetics of Mullerian duct anomalies includes, it could be sporadic, it could be familial, multifactorial, autosomal dominant, autosomal recessive, X-linked, variants of GALT, and then genes associated are HOXA9, 13, and WNT4. So when we look at the embryogenesis of the reproductive tract, the male organs develop from the Wolffian duct, but the female genital tract, internal genital tract, they occur from the Mullerian duct, which occurs as two ducts on either side, which comes to the midline, which fuses, then differentiate, then canalizes, and ultimately forms the tube, uterus, and the upper part of the vagina. And the lower part of the vagina is developed from the sinovaginal bulb, which gets communicated with that of the upper one third of the vagina. So then, for anything we need to understand this disease process, we have to have a definite classification. It was the first classification was made in the year 1979 by Buttram and Gibbons, where the first thing is Mullerian agenesis, that is class 1, where it could be a vaginal agenesis or a cervicovaginal agenesis, or it can be agenesis of the fundus or the tubes, and sometimes you don't have the tubes, and the Rokitansky syndrome comes under this. Then comes the class 2, where there is uniconvate uterus, and the other horn of the uterus, that is the other Wolffian duct, developed, but it is partially developed. It can have an hypoplastic uterus that may be communicating with the uniconvate one on one side, or it may not be communicating, and there may not be any endometrial tissue, or sometimes the entire Wolffian duct fails to develop. So that is the uniconvate duct, uterus. Then comes the uterine didelphys, where there is total failure of this Mullerian duct to fuse. So you have both sides, the uniconvate uterus that develops on either side, and you call it as an uterine didelphys. And the uterine didelphys, they have a tubes, uterus, and then the cervix, and sometimes it can extend up to the vagina and dividing the vagina into two, where it is a total uterine diadelphys. Then comes the class 4, where you have the biconvate uterus, biconvate bicorporeal, where there is again failure of the thing to fuse, but there is partial failure. So unlike this uterine diadelphys, where there is total failure, here you can have a complete, like in the upper fundus portion of it, you can have the uterus, but in the low, as you come down lower, it will be a single cervix. And it again, if there is developmental, this thing can be only partial, or it may present as an arcuate uterus. And then you have the class 4, that is the septate uterus, where the septum may be totally, that is failure of resorption of this two. Whenever these two horns, when the Mullerian ducts they fuse, failure of these two ducts to disintegrate the septum and make a single uterus that fails, and that can be a complete septum or a partial septum. So this is again in 1988, the American Fertility Society classification of Mullerian anomalies were brought together. So here it is something very similar to the previous one, where the hypoplasia can be at the level of vagina or the cervix or the fundus or the tubes, or it can be combined. Again, it is the same as uniconvate, what we saw in Bartram's classification, then uterine diadelphys, biconvate, septate, arcuate. And the extra one thing that is given here is a diethyl stilbestrol induced developmental abnormality, where it is usually a T-shaped uterus that is occurring. And again, the tubes may be duplicated, or the tubes can have some abnormalities. So this is, they say this is probably secondary to the diethyl stilbestrol exposure in utero. Then comes the ESG classification of Mullerian anomalies, where the U0, that is, it is the normal one, and U1, it is slightly a dysmorphic uterus, that is, it could be infantile or it could be a T-shaped uterus. It is, you imagine, it is the reverse of the previous one. Or it could be a U2, that is where there is a septate uterus, partial septum or a complete septum, and a bicorporeal uterus, that is a biconvate uterus, where it can be partial, complete, or incomplete. Then again, you have the hemiuterus, that is the uniconvate uterus. And then comes the aplasia, that is U5. So it is actually the reverse of the previous one. So again, this X-ray ESG classification has got the advantage of modifying the coexisting abnormalities of the cervix and the vagina are also expanded here. C0 means normal, C1 means septate cervix, C2 is double cervix, and C3 is unilateral cervical aplasia, and C4 is a total cervical aplasia, where there is failure of the development of the cervix on the upper 1/3, and the lower 2/3 of the vagina develops, and as well as the fundus of the uterus is there. And again, V0 is normal vagina, V1 is a longitudinal non-obstructive vaginal septum, V2 is a longitudinal obstructive septum, V3 is a transverse septum or an imperforate hymen, or V4 is a total vaginal aplasia. They have given one more compartment, that is U6, for the unclassified malformation. Some of the malformation, they don't fit into any one of this, and they can be put in this. So then came the ASRM Mullerian anomaly classification of 2021 to 2022. The advantage here is it can be divided as Mullerian agenesis, cervical, uniconvate, uterine diadelphys, biconvate, septate, longitudinal vaginal septum, transverse vaginal septum, and complex anomalies. And the thing is, you have to, it should be goals of ASRM Mullerian anomaly classification is, it should be recognizable as based on the 1988 ASF classification system, describe the anomalies involving the uterus, cervix, and the vagina, standardize the terminology and make it simplify so that the communication is quite easy and recognition is also easy, and identify with the scientific databases can be made with this. So this is what you can scan this QR code, and then you can get this Mullerian anomaly classification. Again, the anomaly starts from the Mullerian anomalies, cervical agenesis, uniconvate uterus, and then you have the uterine diadelphys, and you have the biconvate uterus, then again the septate uterus, and you have the transverse vaginal septum or the vertical vaginal septum. So the longitudinal vaginal septum can be partial or it can be total, and you see it is a different anomaly where there is an obstruction in the hemivagina in a uterine diadelphys. Okay, so, and then again, you have a longitudinal vaginal septum, either in a septate uterus or it could be a uterine diadelphys. So then comes the, this is what I said, there will be absence of failure of the cervical thing, uterine isthmus and the cervix to develop. So coming to the incidence of Mullerian duct anomalies according to American Fertility Society is that majority is contributed by the arcuate uterus and the septate uterus, 33% almost, and biconvate uterus in 20%. D is exposed uterus. It is only 0.8, but I should say that we do not use DES no more, and hence the fetus should not be suffering from this, probably because of DES exposure. Maybe something else is a cause for that. Then you can have uniconvate uterus in 33% and uterine diadelphys in 33%. So what is the effect of Mullerian duct anomalies upon the reproduction? It can lead to infertility. The incidence of endometriosis is found to be higher in the Mullerian anomalies rather than in the general population. It can lead to ectopic pregnancy, recurrent pregnancy loss, premature delivery, intrauterine growth retardation, fetal malposition, increased perinatal mortality because of IUGR and prematurity, and it can lead to uterine dysfunction, and failure of normal progression of labor can happen, and uterine rupture can also occur. So then coming to the obstetric significance of the vaginal abnormalities, when there is a complete Mullerian agenesis, pregnancy is not possible because uterus and vagina are absent. About 1/3 of the women with vaginal atresia, they have associated urological anomalies, and complete vaginal atresia precludes intercourse and then pregnancy. In most cases of the partial atresia, because of pregnancy-induced tissue softening, obstruction during labor is gradually overcome and interferes with the descent. That is, whenever there is a partial atresia, that is, when there is a vaginal septum that is present partially, during labor, it can cause obstruction. Then comes the complete longitudinal septum or an incomplete septum, which can again interfere with the descent, or sometimes if it is going to be a small fetus, the fetus descends and dilates satisfactorily. Cervical abnormalities are something terrible because so long it has been difficult to correct the cervical abnormality. But it can be either a total atresia or a double cervix or a single hemicervix or a septate cervix. And this double cervix, you need not worry because it is associated with uterine diadelphys, and a single hemicervix that occurs because of the unilateral Mullerian abnormality. And then septate uterus can be a part of the total septum that is extending into the cervix also. Whenever there is atresia of the cervix occurring along with the upper vagina, then what happens is the patient presents with a primary amenorrhea and she starts developing hematometra, and there is no way that the menstrual blood can come out. But of late, we have an excellent treatment for this atresia where it can be surgically corrected, either mostly by laparoscopy, where the lower part of the cervix, lower part of the uterus can be cut open, and the cervical portion that is absent, that can be linked with the upper portion of the vagina. So by this, the anatomical entity can be brought down and the patient can start menstruating, and few cases have been reported pregnancy following this. So then how to diagnose? First thing is clinical suspicion, then hysterosalpingogram, USG or SSG, MRI, and histolaparoscopy and laparotomy, or during LSCS we can diagnose. So the hysterosalpingographic findings are, it is a normal uterus, it's an arcuate uterus, it is again a septate uterus, it is a biconvate uterus, you can very well see both horns are separated, and it is an uniconvate uterus where you do not see the other horn of the uterus, and here it is a uterine diadelphys where there is totally seen separately. So then comes the ultrasound images of the Mullerian anomalies. So what was seen in the hysterosalpingogram is being repeated here. Normal uterus, arcuate, and then you can have the biconvate uterus, you can have the uterine diadelphys showing 2 cervical canal, and uniconvate uterus, and it is the septate uterus. Then this can be better picked up by the 3D ultrasound, which is at par with MRI. Again, you can see the normal one, banana-shaped uterus, which is an uniconvate one, and you see the biconvate one. Here also a biconvate one. Here it's a septate one where the septum is almost here. If you see the fundus, it will be flat or you can see it almost flat or convex in the case of septate uterus, but when it comes to the question of biconvate uterus, then it will be more convex. Okay, then you can see a T-shaped uterus, arcuate uterus. Again, it is a septate uterus. So this MRI is the one that can confirm. 3D is enough to diagnose uterine anomalies, but if there is any doubt regarding the diagnosis, then we can go in for MRI. Here it is an arcuate uterus. Here it is an septate uterus, uniconvate uterus. Again, it is a septate uterus. You can see a biconvate uterus here, uterine didelphys, where 2 cervical canal are seen, and here it is again a biconvate uterus. Then comes the laparoscopy. Laparoscopy is ultimate, which can diagnose as well as treat the abnormalities. The septum can be resected, and if it is associated with endometriosis, it can also be corrected. So now let us see what are all each. Class 1 is Rokitansky syndrome, where there is failure of the development of the uterus, fundus of the uterus. So the patient usually, the fundus as well as the entire uterus may be absent, and the patient may present with features of primary amenorrhea. And because the ovaries and tubes are there, the patient will be very feminine with the development of the breast, and it will be they will be having a short vagina because the lower 2/3 of the vagina develops from the sinovaginal bulb. And it has to be differentiated from testicular feminization, and the differentiating technique is you go for a karyotyping, where it will be 46XY in XX in Rokitansky syndrome and XY in testicular feminization syndrome. And these patients with testicular feminization will not have the development of the breast. So the investigation is what I said is by karyotyping, ultrasound, MRI, hormone assay, IVP. If you think that it's associated with vertical anomalies, and renal sonogram can be done. But now we can pick up the renal deformities, absence of renal thing, or a pelvic kidney or vertebral anomalies can be made out by MRI. And diagnostic laparoscopy is routinely not done. If it is for some other reason, maybe we can find out. So this is a case of Rokitansky syndrome, where you can see the uterosacral everything. There is a small uterus which is non-canalized, and the tubes are seen, and you have the ovaries that are present. Usually the ovaries are there. So now you can see the tube and the ovary. So now what is going to be the treatment? The presenting feature will be primary amenorrhea, and the patient will have the beautiful breast development, and they will have the short vagina. So how can you treat it? Previously, these women were scheduled for vaginoplasty just to have a sexual life. The varieties of vaginoplasty that are done, McIndoe's vaginoplasty, Williams vulvovaginoplasty, Vecchi's procedure, and Devidas procedure, which are both through laparoscopy. And Purushothaman's vaginoplasty is found to be very ideal because it has got a vascular flap, and there is no need to use an amnion, or we did not use the hairy portion of the vulva, may not be used. Again, fertility is currently possible by surrogacy, and you have the uterine transplant which is coming into O. And because of the uterine transplant, these women are capable of delivering a baby either mostly through ART. And we need to give a good psychological support to these women. Then comes the class 2, that is the uniconvate uterus. As I have mentioned earlier, the unilateral failure of development of the Mullerian duct anomaly, and the incidence varies according to different textbooks and the different literature. It can be somewhere between 13 up to 33% they have reported. Again, the types are uniconvate with the rudimentary horn, the horn which is communicating or non-communicating horn with the endometrium and without endometrium. So the non-communicating horn with the endometrium is very dangerous because there can be a transtubal spill of the fertilized ova that can get implanted, and it can lead to an ectopic pregnancy or a carnival pregnancy. It is often associated with renal anomalies, horseshoe kidney, and pelvic kidney. Clinical features are hematometra in one horn, endometriosis. Because of that, they can land up with preterm labor. That is the uniconvate uterus. Mostly they will land up with the preterm labor, or they can have IUGR. Malpresentation can happen, and ectopic pregnancy is very common. And pregnancy in accessory horn that is what I told. Ectopic pregnancy can happen that will lead to the rupture of the uterus. So then coming to this is what the communicating horn, this is with the endometrium, non-communicating with the endometrium. This is most dangerous. And again, no cavity, nothing to worry. And sometimes there may be no horn. So the diagnosis is, as I have mentioned earlier, by HSG, USG, and MRI. And laparoscopy is indicated for excision of the rudimentary horn, which has got endometrium. IVP and renal sonography can find out the associated renal abnormality. Cervical encephalography is mandatory if the patient conceives, and this is the HSG picture, USG picture, and the MRI picture. And this is the laparoscopic view of the unicorn weight uterus, where you see the other right side rudimentary horn, which has got no endometrium. And you see the tubes are also partially developed, but it has got a good ovarian reserve. And on the other side, the uterus and the tubes, ovaries, everything is normal. And this patient is likely to conceive if, because she has got a patent cervix, can conceive through the left side. So this is the hysteroscopic view where you can see the carnua. Suppose if the patient has got lands up with the premature labor, then the best thing is what you can do is on this side, you can extend the cavity by doing a lateral metroplasty. Then they have higher incidence of infertility, endometriosis, and dysmenorrhea. And implantation in a normal sized hemiuterus is associated with increased risk of abortion, preterm delivery, and intrauterine fetal demise. So that is why we need to put a lateral metroplasty this side so that the cavity can be enlarged. So what will be the reproductive outcome? Live birth is 43.7%, abortion rate is 35 to 43%, preterm delivery is 27%, and term delivery is 31%. So almost more than 50 to 60% of the patients can have a live birth rate either through preterm delivery or through term delivery. Then coming to the class 3, that is uterine didelphys, it is similar to the unicorn weight uterus, but only thing is both the horns are developed, but there is failure of fusion. So they can also have the same complications like preterm delivery, fetal growth restriction, malposition, and higher risk of cesarean delivery. So the incidence here is 11%, and the types can be, the didelphys can be totally two Mullerian ducts, where there may be vertical septum extending even up to the lower portion of the vagina. So you can have a cervix here one more cervix, and the vaginal septum will be down. So regarding this, it can cause sometimes, how do they present? Sometimes they may be asymptomatic if both cervix are being opened out. Sometimes what happens is, if there is obstruction to one of the uterus at the level of the cervix or at the level of the vagina, there is failure of the tampons to obstruct the menstrual flow. That means when you place a tampon, there will be obstruction to one side, and other side, suppose if it is open, they can cause menstrual flow. Or if it happens to be obstructed, it can lead to hematometrocolpus, hematometra, hematosulfix, and endometriosis. And there may be 20 to 30% of associated renal anomalies or bladder extrophy, congenital VVF, and cervical agenesis. So these are the imaging modalities. HSG can see two totally different one, and 3D ultrasonogram can differentiate two things. And then MRI can have two different uterus with a different two individual cervix in the vagina. And here it can be also confirmed by laparoscopy. See, this is a laparoscopic view where you see invariably you can see uterine didelphys, both sides you can see the tube. When you inject the dye through one cervix, you can have the patency test, and there is always, many a time, there will be a band of tissue extending from the bladder to the anterior rectum, and you can see the associated presence of endometriotic tissue in the uterine didelphys. So if you see the hysteroscopic view, you see one carnua, okay? And then you have to come out and entirely go through the other cervix to find out the other horn. So how to manage surgically? Only patients who have obstruction have to be managed. Otherwise, they have to manage by excision of the horn that has got an obstruction. Otherwise, no obstruction means nothing can be done. And metroplasty, Strassman's metroplasty is indicated in selective cases where there is recurrent midtrimestral loss. And whenever these patients, they conceive, it is better to have a cervical encerclage for this patient. The reproductive outcome is term delivery is 20%, ectopic 2.3, abortion 20%, live birth rate, even inclusive of preterm delivery, it can go up to 70%. So regarding this particular patient, I want to tell you that is this patient, I inseminated her 3 years back during the COVID period. She conceived on the right horn and she delivered by LSCS. Again, now she has come back for the second time, and now this time she was very keen on getting it inseminated on the right side because it was on the same side she had a pregnancy previously. I'm waiting for the result to come. So then comes the class 4 and the class 5. There is the biconjugate and septate uterus, which forms the majority of this uterine anomalies. Here we have to differentiate biconjugate uterus. It is because of the thing is abundant muscle tissue, but whereas in the septate uterus, you can have the muscle tissue as well as the connective tissue, and the pregnancy losses are first 20 weeks are reported by Buttram and Gibbon, and 70% of the cases for biconjugate uterus, pregnancy loss can happen, and in septate uterus, it goes even up to 88%. There is also an increased incidence of preterm delivery, abnormal fetal lie, and cesarean delivery. Then biconjugate uterus incidence is 20%. It can be complete, where it can be biconjugate, bicolis. That is, you have the two entire uterus and the two cervix are there. Or it can be incomplete, where, see, it is a total one. You have one horn, two cervix. And then, so it is complete. Or when it is going to be partial, you have a single cervix. Or it is something arcuate, where it is found only in the fundus. So here again, how to differentiate between the septate uterus and the biconjugate uterus, that is very, very important. If you do a 3D ultrasound, if you see look at the fundus. If the fundus is convex, then you can say that is most likely to be septate uterus. And from the carnivore, if you measure the distance, you have to measure the distance. It will be greater than 1 centimeter. But if you look at the biconjugate uterus, what happens is the fundus, there is a concavity facing towards the cervical level. And if you measure this, both carnivore and the distance between the fundus to this, it is always less than 1 centimeter. Sometimes what happens is when it is going to be a deep biconjugate uterus, the fundus, the convex portion of the fundus may be even below the transverse line that is drawn between the two carnivore. So the clinical features, it can be asymptomatic, it may present with recurrent abortion, preterm labor, and live birth rate is around 65%. And how will you diagnose? It has to be mainly differentiated by septate uterus, by HSC, by ultrasound, by MRI, and intercarnival distance. If it is greater than 105, then you think, so it is being wide, it is biconjugate. And the myometrial tissue is seen in the biconjugate uterus versus septum. In the septate uterus, and the angle is less than 75 degree, and it is usually picked up by combined laparoscopy and hysteroscopy. Here you see a biconjugate uterus along with a fibroid in one horn and associated endometriosis. This was taken some long time back, and just after the you can see both uterus, which are both the ovaries that are kissing in the posterior side, and the endometriotic tissue is seen, and you can see the ovaries and the tubes that are buried below. And just when you dissect it and when you retain the anatomical thing, you can see this chocolate material coming down. And this ultimately, this fibroid can also be removed by myomectomy. This patient also conceived. So then the surgical management. Metroplasty is reserved. When do you do metroplasty for biconjugate uterus? Biconjugate uterus, in general, we do not do anything much. But in recurrent abortus, you can go for Strassman's metroplasty, where you can cut it and then unification surgery can be done. But if it can be done either by laparoscopy or laparotomy. And in these cases, if the patient conceives, it is better to deliver them by 36 weeks of pregnancy. Reproductive outcome in biconjugate uterus, there is an increased incidence of biconjugate uterus in infertile population with a term delivery date of 60%, and metroplasty is indicated only when other causes are ruled out for recurrent abortion. Then coming to septate uterus, which is a very, very common Mullerian anomaly, and incomplete resorption of this medial septum is the main reason. It can be complete or it can be incomplete, and it has to be differentiated from uterine didelphys, and renal tract anomalies are found to be less common in septate uterus. Here you see the septate uterus where the septum is totally comes here. As I said, mentioned earlier, you see the fundus, it is always convex. And then in here, it is a partial septum. So this total septum sometimes can extend up to the vagina also. In these cases, it has to be totally differentiated from uterine didelphys, and total septum, separate uterus has to be differentiated. So these are all the imaging modalities. Is HSG, you can see in their ultrasound. 3D ultrasound makes it very clear. MRI still more clear. Again, you see, always look at the fundus. If it is convex, it is separate uterus. So the common features are, it can cause dyspareunia, dysmenorrhea, primary or secondary infertility, recurrent abortion, and recurrent poor reproductive performance is a common cause. So how do you manage it surgically? Hysteroscopic septal dissection under laparoscopic guidance using microscissors or electrocautery or laser or versa point, and stop dissecting when both carnevae are seen in the same plane and appearance of vascularity is there, and move the scope from one side to other. So now you can see this case of septate uterus where there is some small fibroid here, but it is not associated with any endometriotic tissue. So as there is a small fibroid again. So again, you can see this hysteroscopic view where when it enters one horn, it is in the left side. So you can see the carnua here, and then you have to come out. You get into the other horn, you can see the carnua there. So now the septum is almost up to the, extending up to the middle 2/3. So this carnua is here, and then using Collins knife, you can cut it. So it is a monopolar cutting current where it is being used, and it can go up to, you have to cut it as long as you find the blood vessels that are opening, or you have to find the carnua, both the carnua. So this is quite a broad septum. So that has to be cut with a Collins knife. So you have a bipolar thing also available where you can see a, we can use normal saline. So this is again another case of septate uterus where you have found the associated endometriotic tissue are there. So this can also, so now our thing is we have to remove the endometriotic tissue, clear the do a cystectomy, then mobilize the uterus. And then when you go for a hysteroscopy, you can see one horn here. You can see that is the left side. And then you come out and it is almost a total septum where it will be looking like an owl's eye sign. So here also I am using only the monopolar cutting current. Again, when to begin with, it will be very thin septum. But as you go higher and higher, the septum may be again very thick, and be careful that it has to be in the same plane as that of the carnua. Sometimes undercutting is quite safe because of the rupture of the fundus during pregnancy. I have seen this in earlier part of the career. Then comes, nowadays I have started using only scissors, cold scissors for cutting the, you can see this septum here. And this is divided. The main advantages, you need not go for glycine, and you can safely use the normal saline, and then you can cut it slowly. So you insert the scissors tip and you can open it out. So gentle movement, gentle strokes. Every cut will be only 2 to 3 millimeter, and hence there is no chance of injuring the fundus also. Even if it is going to be a small nick in the fundus, don't worry, because you are not using the cutting current. So this is quite found to be quite safe. So then again, what will be the reproductive outcome? Spontaneous abortion can be 75%, up to 75%, live birth rate, term deliveries and preterm labor, and ectopic. And once when you do metroplasty or what is called a septostomy, that increases the incidence of live birth rate. Now again, there is a controversy whether you need to follow up the patient with estrogens or COCs. All those things they can be used, but there is no need to use IUCD or a Foley's plug, and the patient can very well plan the pregnancy after 3 cycles. I never use any post-operative IUCD or estrogens. Occasionally, I do use. So the complication is uterine perforation if it is being cut at the fundus to more depth. Hemorrhage can happen. Cervical incompetence can happen in the subsequent pregnancy, and sometimes there may be a undercutting can lead to residual septums, which can always be very safe to repeat hysteroscopy. So then coming to the arcuate uterus, which is a mild deviation from the normally developed one, and the arcuate uterus is almost complete resorption of the uterovaginal septum. Only a little thing is there, and it can be picked up by HSG, and the incidence is almost 30%. And there is no need for any treatment unless the patient has got recurrent abortion. So these are all the HSG findings, UHG finding, and MRI findings, and the reproductive outcome is quite good with almost a live birth rate. Everything is almost very good, and ectopics can still be 3.6% in a general incidence of 2 to 4% in all Mullerian anomalies, and miscarriages can happen. So then about the diethyl silvestrol, I have mentioned currently we do not see much of the cases, but we do come across a lot of this T-shaped uterus with a narrow cavity, which can always be improved by putting by cutting on the lateral side. Sorry, I missed the video of that lateral metroplasty can be easily done, but whatever it is, the cerclage is essential in the event if the patient becomes pregnant. Then coming to few of the rarer anomalies, that is Hurlin-Werner-Wunderlich syndrome, where there is an unilateral obstruction to the uterus diadelphys at the level of the cervix and vagina. It can, whenever there is obstruction in unilateral side, that develops into a hematometra or the hematosalpinx. They can be associated with ipsilateral renal agenesis, and it is often associated with hematoma. So this is the pictorial one where this uterus is being obstructed either at the cervical level or the vaginal level. So resulting in that there is hematometra, hematosalpinx, and there may be endometrioma. So this is often associated with the absence of ipsilateral kidney. So here you see this vagina, there's this septum vaginal obstruction at any level. It can happen or at the cervical level. So now this is the MRI picture, and then this is the MRI where there is absent failure of the kidney on the ipsilateral side. So this is one such case. We had series of 4 cases. You can see the hematometra on one side. So this was that hematometra, and this patient was just a 13-year-old girl who presented with recurrent severe dysmenorrhea, which was progressing. She had an endometrioma also. And the main thing is you have to knock off this hemiuterus, or the hemihystectomy can be done. And this particular patient has conceived and then delivered. And among the 4 patients, 2 of my patients have conceived and delivered, one through vaginal delivery and the other patient through section, and one patient had an IVF and she did not conceive and she did not turn back, and the 4th patient last followed. So this is again a case of biconjugate uterus with obstruction to one side. So this has to be again dealt with in the same way. Then again, another very rare Mullerian anomaly is a Roberts uterus, which is very often associated with endometriosis. This happens in 1 in a lakh, and it was first reported in the year 1970. AFS classification of Mullerian anomaly does not describe this, but Eshrei ESG classification, I said that there is a class, there is a separate place for this complex Mullerian anomalies. It is U2, U6, cervical O, vaginal O. So then that means there is no cervical anomaly, there is no vaginal anomaly, but there is uterine anomaly. The diagnosis is always difficult because the patient has got an atypical septum. So this is the ultrasound where you see the hematometra on one side. You can carefully, when you see the other normal side of the uterus is being compressed, and you have a vagina. So this particular girl, she was menstruating, and after menarche, there was a progressive dysmenorrhea. So this is a laparoscopic view. So this patient first initially they thought since there was a presence of endometrioma, they thought this endometrioma was there, and that was the cause for pain, and they had knocked off the right ovary and the right tube. Following that also, the patient continued to have pain, and again the third surgeon, they have done opening of that hematoma and drained it. Unfortunately, the patient was put on DMPA, and she stopped menstruation through the entire period, and after that she reached us. So this was the hysteroscopic view where you can see one horn. One cornua is seen, the left cornua is seen, and I hope you remember the picture of right side hematometra, and you see the bulging septum. So the lower margin of the septum is here. It is not extending up to the cervix. So when you cut it with a Collins knife at one space, you can see the entire, when you open it up, you can see the so you can, through the hole, through this hole, the septum that is being cut open, you can see the gush of brownish chocolate material. And hence, once when the septum, atypical septum is cut, I excise the excess portion of the septum. So let us see how it occurs post-operatively. So this was the post-operative view. After 3 months, it was taken, where you see this something, this looks like a subseptate uterus, and this horn is quite seen, well, carnivora is seen, and this horn is quite deep. That is probably because of the marsupialization that was done in the previous surgery. Maybe if the patient conceives, then we have to think about complications of placental accreta symptoms. Or probably I have advised this girl to come back for a revision of this particular defect. Okay, so this was our experience with the septate uterus and the pregnancy outcome. We had around 56 women who underwent septal resection. And then again, following this patient, we found out that the increase, 79% of the patients had achieved a term pregnancy, and only few had miscarriages, and ongoing pregnancy was quite high. So just by means of doing a septal resection or septostomy in selected cases, we can have a better outcome. So this was a study of Mullerian anomaly between the year 2011 to 2023. We had around 179 women with the outflow obstruction. 66% had endometriosis. Septate uterus in 146 cases, and about 15% they had endometriosis. Whenever there was no obstruction like biconjugate uterine didelphys or uniconjugate, again there was incidence of endometriosis. And whenever there was no endometrium like in Rokitansky, there was no endometriosis. So to conclude, Mullerian anomalies are not so common, presents at varying stages of life as primary amenorrhea, infertility, recurrent abortion, preterm labor. MRI helps in accurate diagnosis. DHL is indicated when intervention is needed. Corrective surgery definitely improves the pregnancy outcome. And I thank you for your patience listening. Gayatri, Chitra?
Ma'am, am I audible?
Yes.
Hello.
Yes.
That was a very, very elaborate talk touching every aspect of Mullerian anomalies as possibly we can think of. Thank you very much, ma'am, for that. And now for the case presentation, I'd like to call upon our ICOG fellow, Dr. Ashika.
Ma'am, is my screen visible, ma'am?
Yes, visible. Go ahead. Go ahead.
Firstly, I would like to thank Dr. Ramu madam and Dr. Chitra madam for entrusting me with this case presentation again. So moving on to the case presentation. 25 years, Mrs. X, wife of Mr. Y, who's 32 years, coming from Mayiladuthurai, who's a homemaker, belonging to the lower middle class status, married since 3 years, was referred to a center with history of recurrent pregnancy loss. Menstrual history: she had regular cycles lasting for 3 days, once in 30 days. Her flow was normal. She had history of dysmenorrhea for the first 2 days of menstrual cycle. No history of passage of clots. Marital history: she was married since 3 years. It was a non-consanguineous marriage. Past history: no history of diabetes, hypertension, thyroid disorders, tuberculosis, cardiac disease, inherited thrombophilias, or blood transfusion. No history of any past surgeries. Personal history of mixed diet. Her sleep and appetite was normal. Bowel and bladder habits are normal. She had no addictions. No history of drug or food allergy. Partner history.
Okay.
He is an electrician by profession, not a known smoker or alcoholic. No history of sexually transmitted disease. no history of genital trauma, no history of past surgeries, no history of varicocele. Family history, no history of genetic or congenital abnormalities or any early pregnancy loss in the family. Obstetric history, she was P0A4. Her first pregnancy was a spontaneous conception after 3 months of marriage. She confirmed it by urine pregnancy test at home after 1 week of missed period. Patient had a spontaneous abortion at 60 days. USG was not done and DNC was not done. Her second pregnancy was also a spontaneous conception after 3 months of previous abortion. Confirmed it with UPT at home after 1 week of missed period. Patient had USG done this time in Mailaduguri GH in the second month of pregnancy, which showed a single intrauterine gestation of 7 weeks with cardiac activity. Unfortunately, she had a spontaneous abortion at 8 weeks. DNC was done at Mailaduguri GH. Patient was advised preconceptional folic acid. No further evaluation was done at this point of time. Coming to the third pregnancy, it was also a spontaneous conception after 5 months of previous pregnancy loss. UPT done at home after a week of missed period was positive. Patient had an ultrasound done which showed single intrauterine gestation of 6 weeks with no cardiac activity, and hence patient was followed up after 2 weeks. After 2 weeks, even then the scan showed a single intrauterine gestation of 6 weeks with absent cardiac activity. Hence, a diagnosis of missed abortion was made. DNC was again done at Mailaduguri GH, and this time the products of conception were sent for karyotyping since it was the third abortion, and patient was advised to investigate for the cause of recurrent abortions. So, basic investigations were done with a complete blood count which was normal, her bleeding and clotting time was normal, sugars were normal, and thyroid stimulating hormone was 2.20. APLA was negative and the karyotyping of the conceptus was normal. Patient was advised for further management at tertiary center, but patient did not take any further treatments. Her fourth pregnancy was again a spontaneous conception after 4 months of previous abortion. UPT was done at home, which confirmed pregnancy. Patient had ultrasound done at Mailaduguri GH, which showed a single intrauterine gestation of 6 to 7 weeks with cardiac activity. Her antenatal blood investigations were normal. Patient was referred to government tertiary center for further management. Patient went to a private hospital to take the further management. Patient was started on blood progesterone support with capsule sustain 200 micrograms and tablet aspirin 75 milligrams along with folic acid at the private hospital. Her first trimester was uneventful with an NT scan and double marker screening test was normal. Patient was advised meal plan at 4th month because her glucose challenge test was 142 milligrams per deciliter. Again, unfortunately, patient had sudden pain and bleeding at 5th month of pregnancy and spontaneously expelled a male fetus of 200 grams at the private hospital. No features of congenital anomalies were present in the fetus. Her post-abortal period was uneventful. Patient was then referred here for further evaluation and management. So, case summary. 25 years, Mrs. X, wife of Mr. Y, coming from Mailaduguri with history of dysmenorrhea during menstruation, with 3 spontaneous first trimester abortions and 1 spontaneous second trimester abortion, with history of DNC done twice, has been referred to our center for further evaluation and management. On general examination, she was moderately built and nourished. Her BMI was 26.5. Vitals were normal. No pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. No signs of hyperandrogenism. Her bilateral breast examination was normal. Thyroid, no enlargement. Systemic examination was also normal. Her abdominal examination was soft, non-tender, no palpable mass or no organomegaly. Gynecological examination, her external genitalia was normal. Pubic hair normal, no local lesions. On speculum examination, cervix and vagina appeared healthy, no septum, no discharge. Bimanual pelvic examination, uterus was normal size, anteverted, non-tender, mobile, bilateral fornices free, no fornical tenderness. So we investigated the female partner and her blood investigation seemed to be normal. A thyroid stimulating hormone was 5.8 and at this point we started her on tablet Thyronorm 50 micrograms. And on doing a 2D ultrasound, we had a suspicion of query septate uterus or bicornate uterus and the patient was subjected to 3D ultrasound, which confirmed the impression of a septate uterus. So the patient was then planned for hysteroscopic septal dissection and the intra-op findings showed a normal ecto and endocervix. The cavity had a septum present up to the lower third. Both the cornua were seen and endometrium was normal. The septum was resected with Collins knife. And sorry, I have written it as monopolar resectoscope. So this, luckily, I could get the video of the septal resection done for this patient. So this is the septum that is in the middle. This is the left side cavity, and the other cavity is seen. The septal resection was performed by Dr. Ramani Madam. We could see she is using a Collins knife and resecting the septum from the apex towards the fundus meticulously.
There are, Yeshika,
Yes, ma'am.
there are many things that you can use to cut this septum. Okay.
Yes, ma'am.
That is like, they say now you can use scissors to cut. You can use monopolar cautery to cut. You can use bipolar cautery to cut. You can use this Collins knife. Of course, you add on. Actually, this is also connected to cautery. This is connected to monopolar cauteries. See, what is the difference between using a dipolar cautery and a monopolar cautery? What are all the advantages? Have you thought about all these things? Do you think you should convey all this to the audience as well?
Yes, ma'am, definitely. Like you said, ma'am, monopolar cautery by using, we need to use a media which is a non-electrolyte containing media like glycine.
Yes, that's very important.
Yes, and with that, where fluid deficit should be monitored meticulously, and this has a complication of hyponatremia, which occurs like every extra 1 liter of glycine that we give will lead to 10 milliequivalents of decrease in the sodium levels, which may lead to hyponatremia and further consequences like pulmonary edema, cerebral edema, and transient blindness. So in that way, bipolar would be better because it needs an only normal saline for the medium to get distended. And even though we use normal saline for bipolar, it also has a consequence of fluid overload, which should be considered. Hence, in all, whether we use a monopolar or bipolar electrocautery, what we should keep in mind is the meticulous monitoring of the fluid deficit.
For any hysteroscopic procedure, that is a very important vital thing that has to be monitored. What you are putting in and what is coming out should be measured. If you think you are running deficit, you should just stop the surgery. You should not proceed further. That's an important point that we have to convey to them. Okay, about these two, between using monopolar and bipolar, do you think the scar will be better?
Ma'am, actually, both of them use electric current. So I feel like regarding to the scar, a cold knife scissor would be better option than monopolar or a bipolar.
That's what. That's why many of the hysteroscopic surgeons have now started moving. Actually, the septum is totally avascular. So even if you use a scissor and cut it, it's not going to bleed. If it's going, we all say, when you should stop is when you see really blood coming out. That means you have already reached the myometrium. You are actually digging into the myometrium. As long as you are in the septum, you don't have bleeding. So using a cold knife or a scissor to cut it is much better than using a cautery. That is what now it is very popular. Yes, I wanted to bring in only these ideas. Carry on, you carry on.
I'll just move forward a little bit, ma'am.
Yes.
So as we look at the septum, like we can see the cavity beautifully opening up. And as madam already said, we can, it is better not to overdo than underdo for septum always. And we can stop at the point where we see both the cornuas, and if there are any minimal bleeding points that we see, it is better to stop at that point. And in studies, they have said that it is better to leave a fundic spur of less than 1 centimeter always.
From the internal os, you bring the entire hysteroscope to the internal os, and from the internal os, you should be able to see the cornua, like exactly now. Like from here, if you see, both the osteas, that means you know that the cavity has become one. So you stop short there. Yes. Carry on.
So following which, the patient had a spontaneous conception after 6 months of septal resection. UPT was confirmed at home. She was gravidified, abortion 4. Her LNP was 30th of October 2022 and her EDD was 6th of August 23. She came here for all her antenatal checkup. Her first trimester basic antenatal investigations were normal. NT scan with double marker screening was normal. And this time the NT scan cervical length was 2.3 millimeters. So her cervical encerclage was done at 14 weeks. Her second trimester, patient was diagnosed as GDM at 6 months of pregnancy and started on tablet metformin 500 mg BD. Otherwise, her second trimester was uneventful. And the third trimester was also uneventful. Patient had spontaneous labor pains at 38 weeks of gestation and was admitted for safe confinement. So emergency LSES was done in view of fetal distress. In the intra-op findings, the endometrial cavity appeared completely normal. She had an alive male baby of 2.8 kgs delivered on 27th of July at 4 a.m. Her post-op period was uneventful and the patient was happily discharged on POD 5. So that comes to the end of the case presentation. Thank you.
The take-home message or points from this case is, when there is a BOH, we should always look in for uterine anomalies. That is one of the important investigation that you should do for a BOH. So once you know that the uterus is all right, you can leave the rest. So for that, you have to evaluate the uterine cavity. The best mode that you would do is a 3D ultrasound. So 3D ultrasound will give us very clear idea about the endometrial cavity of this uterus. Okay, when you see the septum, within 3D ultrasound, you can really measure how far it is. See, in this case, it was almost up to the lower third. So you could reach till there, you know what it is, and you know the breadth as well as how much of depth the septum is. So you can plan your resection on the day of hysteroscopy. Otherwise, only when you do the hysteroscopy, you know that you are going into this cavity and that cavity, it is coming up to the internal os. So it's not just stopping short halfway through. So one 3D evaluation before a hysteroscope is always necessary. And when you plan a hysteroscopy, that's what I was saying. Whatever instrument you have to do that. You should stop short before you really go into the myometrium. That is one thing. And you can tell them, what are all the advantages of using bipolar, unipolar, and scissors in doing the procedure. And whichever you are comfortable with, you can do. Because though now a lot of talk is going on about the scissors, all of us have done enough with cauteries. And Ramani has a series of them who have delivered very comfortably after that. And one more thing, what you have learned out of this case is, uterine anomalies, you can always have a short cervix or a cervical problem. So you should always look for it and make sure that you do an encerclage, because we do not know about the myometrium, similar to the myometrial, myometrium and elastic tissue and the other things in the cervix can be very poor. So they can go for a short cervix or an incompetent cervix. Now, one more time, we cannot afford to lose it. So we have to look for it, and if necessary, we have to do an encerclage. So close monitoring from the time she has lost the baby till she next time delivers the baby is very, very essential. So that's what we learn out of this case. Anything more you want to add, Rami? You can always add.
Yes, two more things. Ashika, do you need to do septostomy for all the patients?
Ma'am, I think if the patient has any symptoms which is prominent, like in adolescent girls, you mentioned that the dysmenorrhea and all was prominent for one patient for which you took her for surgery. Like that, in reproductive age group, recurrent pregnancy loss would be prominent. And in such case, we can go for septal resection. If the patient is asymptomatic and she has not any history of abortions or any preterm births, then I don't think we have to go for a routine septostomy for all.
That is the concept. Now we do not go for routine septostomy. But if the patient is posted for ART, it is always safer to go for a septal resection prior to ART, because we don't want to lose even a single baby. Suppose I ask you one question. Suppose you come across a septate uterus, then you are doing a C-section for a transverse lie. What will you do? You want to cut it?
Yes, ma'am.
Yes, because the septum is in front of you. Don't
Yes, I think we
cut
can.
it
We
in the
have to cut
artery.
it because, like,
Yeah.
the next pregnancy might also have a transverse slide following.
Yeah. So instead of that, if you are going to cut it, it might be a vertex presentation. Her chances of delivering is quite possible. Then, regarding
after you deliver the baby, you do all this.
yes. Then, if you are going to see, my last video was cutting the septum with the scissors. So now I have switched over to scissors, cold scissors, using that. Then one more advantage of using scissors is you don't need to use a non-glycine. It can be very well done with a normal saline. We are not bothered about the electrolyte imbalance. Then again, one more thing is, if you are going to use either a monopolar or a bipolar cutting current, then you need to dilate the cervix too much. But when you are going to use a scissors, it is enough if you use a Betoche, which is an office procedure. So that is one major advantage. There is no need for dilatation.
But when the septum is as thick as this, if it is a slender thing with that Betoche, you can cut it off very easily. When it is very thick, it becomes very difficult. You will lose only 2 scissors during the procedure.
You will lose. That is there. Then one more thing I wanted to ask is, no, not all patients with septal dissection, I don't put Emcure class. You have to follow up the patient. That is the only.
You have to look for cervical incompetence.
Yes.
That's what I was saying.
Suppose if you find the total septum. See, if you want to put the resectoscope, you need to put it inside the cervix. So if there is a total septum that is extending into the cervix, like you have a 2 cervix, but it is a septate uterus. What are you going to do? Are you going to resect the septum at the level of the cervix, or are you going to leave it?
Definitely, we have to cut from the level of the cervix so that the visualization of the next part of the septum would be better, ma'am. And
yeah,
then
you can cut it with the monopolar cautery, ordinary cautery, or you can cut it with scissors. And then you can insert the this one. But then again, there are some group of people who say that you, by cutting the septum at the cervical level, you are going to increase the incidence of incompetence. So what they do is they put the Foley bulb through one of the osses, and then use the scissors or a Collins knife through the other one and cut the septum up to the level of the upper portion of the cervix. So the cervix will retain the septum, but the uterine septum will be cut. That's also one technique, but I have not done it because I think it is quite cumbersome. Putting a Foley on one side, small pediatric Foley, and cutting it with the other side. I am comfortable with the total resection of the septum.
Ma'am, I personally have a question to you, ma'am.
Yes.
Ma'am, in your experience, what about the complications that you have faced during septal dissection or any hysteroscopic intervention, ma'am, like perforation or bleeding?
See, maybe in the initial part of my practice, I would have come across perforation when I was doing a myomectomy. But septum, I think I have not come across like any complication. But septum that was done outside, the patient landed with me in a mid-trimester fundal rupture. Fortunately, that patient had a laparotomy done. Fundus was sutured in 2 to 3 layers. And subsequently, that woman was very bold to have 3 subsequent pregnancies, which were intervened by LSCS. Finally, she agreed for the sterilization. And then again, like in the early part, I have had a hyponatremia, electrolyte imbalance, which we picked up much earlier, and with just by intubation and giving them Lasix and correction of fluid imbalance, the patient was all right. But we have to always think about air embolism also in these group of patients. That's along with that is again one dangerous thing.
Especially when you do a myomectomy and when you go deep, you have to think about air embolism. So you cannot, really when you do this type 1, type 2, when it's just inside the cavity, it's okay. But then when you go beyond that, when the portion, that's what estimating everything pre-op is very, very important. So you necessarily, like when she was talking about the septum extending up to the cervix, you have to make sure that it is septum and it is not bicornate uterus.
Yes.
Or uterus didelphys. Okay, all these things should be properly diagnosed and made sure. So initially, if you want to keep yourself guarded, I have done several times with laparoscopy.
Yeah, it is always
So
better to do with laparoscopy.
with laparoscopy, you just don't do it blindly, only hysteroscopy. You put in the laparoscope also, you keep a monitoring there. So that you know, when you are finished, you have not done anything with the fundus. You're not beyond what you should do. So you make sure all these things are done. There is no harm in doing one thing extra to keep yourself very safe and your patient very safe. Instead of overdoing, we can always do a thing with care. So all these things should be learned. And this fluid management is one sister should be doing only that.
Yes,
Because we have no other choice. We are all worried, and when we are doing the procedure, this septum cutting with Kohler's knife is a short procedure. Like Ramani will do it very fast. So, really thinking about fluid overload is never there most of the time. But with fibroid, we get dodged away because we are going on digging. We are trying to do it better. We are not very sure whether we have done everything. So we'll be doing it for a longer period of time. That is the time when we have this fluid overload and we get into trouble.
So first 1 liter deficit, okay. When you cross 1.5, it's a red alert. You stop it. Maybe you can do it. So when you are going on doing a myoma resection, don't remove the resectoscope very often. Don't remove it. You try to push with the pressure of the fluid, the myoma bits separately so that you can visualize. Because every time you bring it out and then reinsert, your vision will be disturbed. So that you should not.
There is actually a small container, vacuum extract also, something like that, with like a ReadyVac. So you can connect that also instead to that suction tube so that you get everything washed away faster. So that you don't get into such trouble. That's a disposable stuff you can reuse also. It's like ReadyVac. You can use that also. Because then you resect a little bigger size. Suppose you have more than 2 centimeters, 3 centimeters. So the bits will be always, floating in that water, disturbing you. So you tend to get it out. So all these mistakes all of us have done when we start. So when it is 1 centimeter, you don't really find it difficult. But when it goes beyond 2 centimeters, it blocks your vision. So you want to get out. So which she says you should not do. That's one important step.
Okay, any doubts in the chat? Questions in the chat box from the audience?
No, ma'am.
No, okay. So I think we are running out of time. We can wind up with that.
Thank you, ma'am. Thank you, Dr. Ramani Devi, ma'am, Dr. Chitra, ma'am. Dr. Yashika has well presented the case. Thank you, audience, for joining with us. Thank you, Emcure, for the technical support. Thank you, everybody.
Thank you.
On behalf of Emcure, we thank each and every faculty for making the program more successful. Thank you very much.
Thank you
very much. Good, Yashika. Keep it up.
Thank you.
Good.